Hello, I'm Hunter Schultz, host of Winning Healthcare Food Fights Without the Mess. My guest today is the executive director of the DPC Alliance, and in his spare time, he has a podcast. Before joining the DPC Alliance, he shaped policy and product development for the American Academy of Family Physicians. While there, he heard about a small group of medical rebels, otherwise known as direct primary care physicians. What they were doing struck a chord with him. He also led a healthcare system's in the trenches primary care transformation and served as a practice transformation consultant for Medicare's Innovation Center. All that experience and more led him to his life's mission, ending the tyranny of the 15-minute office visit with a physician. How that happened and more, starting right now. Welcome to the show, Joe Grundy.
Well, thank you, Hunter. It's a genuine pleasure to be with you.
Well, I'm thrilled to have you on as the director of the DPC Alliance, and I'm thrilled that the Rebel Alliance still lives.
That it does, as you well know. Let's just say the D in Direct Primary Care Alliance on our logo is a fleur-de-lis, and we are very sensitive to Disney's sensitivities around trademark images.
Yeah, true.
So,
yeah,
anything that looks like a Rebel Alliance symbol is purely coincidental.
Yeah, there's a good picture of Dr. Shane Purcell in his Rebel Alliance helmet, which you've no doubt seen. Let's jump right in here because you're doing some great work there, as are the other team members at DPC Alliance. And I've had the pleasure of interviewing a number of members as well as officers, Jack Forbush and Julie Gunther, to name a few, and Shane Purcell. There's a deep problem that I sense going on here. And it's global in nature. And I'd love for you to chat about this because it ties right into your 15 minutes, which I mentioned in the introduction, your life's mission. Medicine has changed so much over the last, 50 years, but especially in the last 20 or so. And even England's vaunted National Health Service, the GPs there are complaining of 10.5-minute patient consults. And that was 2 years ago.
Yeah.
So this indicates a much bigger problem than just the system. It indicates the personalization of medicine requires more time, and that's globally. All healthcare systems are going to run into this along with other issues. And the personalization of medicine means, for someone who's new viewing the show, it means doctors need more time to look at things like genome, look at where you live, work, play, who you are, how you think, getting to know you. Absolutely. Something that's been missing. So how do you feel right now about your 15 minutes, your life's mission, ending the tyranny of 15-minute doctor visits?
It's interesting. So to timestamp this, we are living through COVID and the implications that the COVID pandemic has had for primary care delivery in the U.S. and primary care delivery all over the world has been pretty drastic. But one of those things that kind of in many ways ties to the mission of ending the tyranny of the 15-minute primary care visit is that we've seen primary care go virtual. And that doesn't improve the length of time that primary care doctors are spending with their patients on any given patient encounter. But what we were seeing is that patients have more immediate access and more significant access across multiple points to primary care in their community, hopefully, in an ideal sense. So there is the virtualization of healthcare, so telehealth, virtual care presence, and then there is a growing recognition, as your other guests have all alluded to. Many of them have spoken directly to it, actually, rather than alluding, that we are seeing a new valuation of primary care as an investment in public health, as an investment in personal health for patient populations. And the investment isn't just monetary, it is time. And we're seeing systems now investing in an alternative framework for delivering care with more time budgeted into the equation, from the Johns Hopkins of the world all the way down to independent micro practices. There's a growing resonance with, well, I mean, like, we tried going for efficiency and for throughput, and that's where we ended up today. So maybe we need to try something else. And instead of saying 10-minute, 7-minute, and then just driving down the time available to primary care physicians and their patients, and most importantly, to the patients to understand the care that they're receiving, it's how do we build that back up?
So I'd love to hear the backstory, a little bit of how you're at the American Academy of Family Physicians,
Mm-hmm.
and you stumble across this Rebel Alliance. What's the backstory there? Because it ultimately led to where you're at now.
Yeah, absolutely. At the time, there was no Rebel Alliance. At the time, it was just a handful of mavericks. So this is 2011, 2012. And I had a colleague and a true visionary and leader in primary care named Jay Fetter. He's still with the American Academy of Family Physicians. And he approached me and he's like, "Hey, Joe, you love these alternative models of primary care payment. You really should talk to someone named Dr. Erica Bliss." I was like, "Okay, I'm happy to talk to anyone. What do I need to know about Dr. Erica Bliss?" Well, she's part of something called direct primary care. And many of your guests in previous episodes have really addressed the nuances of direct primary care. But at the time, this is 2011, I was just like,
Early.
What? What do you mean direct primary care? He's like, well, I mean, like, it's you sign for a membership with a primary care physician. You pay on a monthly basis, like a gym membership, and they take care of you like a human being. And that certainly intrigued me. At that point, I've been working in primary care policy and primary care transformation for almost a decade. And I was like, wait, primary care physicians that are paid and incentivized to treat patients like persons? Like, that sounds really promising for some odd reason. And so I had this wonderful call, and I still remember I was sitting alone in a conference room at the AFP headquarters in Leawood, Kansas. I'm talking to someone I never, ever expected to encounter, Dr. Erica Bliss, who's just, first and foremost, a phenomenal human being. And secondly, a phenomenal leader of the direct primary care movement. And she has taken both personal and professional bullets that allowed this movement to thrive. And there's just no way that we can express the gratitude that we need to what she enabled other direct primary care physicians to explore and to build. And so I was learning about it, and I got off the phone and I went to my boss at the time, and we had a team meeting. I was like, we need to do something about this. We need to figure out a way to support this new nascent community. And in 2011 and then rolling to 2012, the American Academy of Family Physicians was 110% behind the patient-centered medical home. It's all we talked about. Institutionally, organizationally, we didn't have bandwidth to really give due credence to anything outside of PCMH, because we felt like we were still trying to get people, and more importantly, physician members, on board with this concept of the patient-centered medical home. And I was just really fortunate that my boss at the time, Sean Martin, who is now actually, as of today, the CEO of the EVP CEO of the AFP, was like, go for it, run with it. I'm not going to tell you not to do this. Like, you have the support you need from the staff, but what you need to do now is put it before our membership and our committees and go through the whole process to see if other family physicians actually care about this thing that you're so excited about. And so he gave me the leeway to just run with it. And we put forward a proposal, or a policy proposition, when the nuances of governance in associations is really boring. So I won't get into it, but we got like family physician leaders who had never heard of this. We're like, wow, this actually sounds really, really promising. I don't know if it's for me, but it's certainly for someone. And we managed to carve out a space in 2013 to get a formal policy from the American Academy of Family Physicians, A, in support of direct primary care, and that B, differentiated from concierge medicine. And I don't know, for the listeners, if they're aware of the distinction, and we can address that down the road.
Sure.
But like, there is an emotional negative response in the family of family medicine to the very term and notion of concierge medicine, right? So if you prick a family physician, chances are you will find a beatnik. The early family physician leaders, they came out like, if you want to talk about Marcus Welby and trading care for chickens and eggs, like that would have been ideal for many of these physicians. So if you're talking about concierge medicine and like this elitist care and really is serving the rich, like they just had no interest in doing anything to do that. So having the bandwidth and the space to write a policy that helped differentiate this new model that was growing up in family medicine really enabled us to get the ball rolling. And I will say, concierge medicine has its place, and it can be a beautiful, beautiful thing. And the relationship that concierge doctors have with their patients can be awesome. It's just not the same as direct primary care.
Yeah.
So from there, I actually took a sabbatical from cutting edge innovation to jump into real world practice transformation work, and then from then to the Medicare Comprehensive Primary Care Plus project, where I was consulting as a national faculty member, and realized that as important as that work was, there was really nothing innovative that was going on. It was just an application of the PCH principles from at that point a decade back. So I got contacted by Dr. Ryan Newhoffel, who said, "Hey, Joe, it's been a while since we spoke. We just formed a physician association for DPC docs. Would you be interested in getting engaged?" And I was like, I'm fully employed. I'm really happy. And I actually tried to get him to hire a few other people. I was like, you need to talk to such and such and such and such. They're in the Kansas City region. Like, they would be amazing supporters, amazing leaders. But things just panned out, and I parted ways with my employer right at the time that, like, Ryan was like, we've talked to those people, and we'd love to keep talking to you. So yeah, I ended up with the DPC Alliance very suddenly, and have been unbelievably happy. Like, it is, working with DPC physicians is such a joy. I was, no joke, early this afternoon, I was talking with a lawyer who works with DPC physicians, and she couldn't stop talking about how much fun it is working with these doctors, and how, like, she was getting doctors, DPC docs, being like, "Hey, by the way, I paid your invoice, but I haven't seen it yet. Like, I just want to make sure that you get paid and everything's okay." And she's like, "Who does this? Why are these doctors so happy and so functional? Like, what's going on?" And I was like, "Yeah, this is direct primary care, and it is the best community in healthcare."
Yeah. If you watch enough shows with the docs, they are, you can just see, you can see the enthusiasm, and so many of them have talked about freedom.
Yeah.
Practicing the way they want to practice medicine.
Yep. I'm enjoying practice again.
Oh, and who doesn't want to who does not want a doctor that loves what they do? It's not that complex.
Yeah, no, it's true. I mean, it's, to go to the far too off-sided quote, like, working with DPC docs is working with a community of people who've found a way to build a lifestyle where they match their avocation and the vocation, right? So their personal passion and their professional passions, and they've made it work. And when those matching passions are healing people and treating patients like people rather than commodities that you can make, like, drop claims against, like, it's amazing. It is fantastic. And I'm a patient of DPC physicians. When I lived in Kansas City, I had an amazing DPC doc. Here in Washington, D.C., where I live now, I have an amazing DPC doc. Like,
Dr. Marguerite Duane.
Duane, yeah, Dr. Marguerite Duane. She is,
Duane.
and she is. I, in full candor, and Dr. Duane knows this. Like, when I signed up with her, I was a skeptic of home-based healthcare, right? Like, I had the notion of someone coming into my space, and rather than me as a patient going into their space and doing, having house calls, which is, I was like, I don't really know, but might as well try this out. Before that, my last doctor was a part of the Kaiser Permanente system, which is, he was an amazing doctor, but it's not exactly a person-centered system.
No.
They do great care, relatively speaking, to the rather low bar set by American healthcare writ large in 2018, 2019. But it's not, I certainly didn't feel empowered as a patient. And, having home visits with Dr. Marguerite Duane for me, my wife, my, at that time, 5-year-old child, like, it was a totally unique experience. And I am sold and a strong proponent of home-based care now.
Yeah, if you can get it. Well, DPC, a lot of docs do it.
Or they'll offer it as an ancillary service for patients who have a hard time moving around. Or one thing that I've seen a lot lately are DPC docs who are offering home visits for newborns, right? So why drag your 8-month-old kid to a pediatrician's office or your family physician's office when they can just come to you? What parent of a 2-month-old child wants to get out the door with the kid and just put them in a car seat and just sit in a waiting room?
If you ran a process chart, a flow chart of that, the typical doctor visit versus Dr. Rebecca Behrens. Yep. She was on the show. She talked about how she goes to the patient's home and they love it. They're a little, are you the nurse? But seeing where people live, how they live, and the interaction gives them much better insights.
Yeah. I mean, it goes back to what you said earlier. It is personalized healthcare, right? If you can spend the time to get to know a person in their environment, you have a very different understanding of them and their situation and their family, and quite frankly, what they're going to listen to than any other framework. And that's not to despair to the DPC docs that don't do home visits, but it is, like I said, I am now a convert. I truly understand that power.
She's taking new patients.
She's not, actually. I am very unfortunate insofar as Dr. Duane is a firm believer in ongoing self-improvement, and she's just taken a fellowship in the great state of Utah. So we are working virtually with Dr. Duane, and then her partner here in town, Dr. Matt. So I think Dr. Matt and some of their partners are taking new patients, but Dr. Duane herself is not. She is living her life and becoming a better doctor and learning how to care for patients better in the way that she wants to, because again, to go to a framework that you said, she has the liberty to do that. Right? She's not bound by an employer who says, well, I need you to see 30 patients for at least 8 months out of the year and 20 patients for at least 3.5 months, which gives you a week, 2 weeks for vacation and family time in times of crisis. Why would we pay you to go for a fellowship to become a better doctor?
Welcome to the old obsolete system. Speaking of which, I'd love to read you an observation that I'm going to put it up on the screen, but DPC docs are handling COVID-19 better than their peers in the old obsolete system. Joe Grundy changed my mind.
I don't think I can change your mind about that. I mean, I'd really have to play devil's advocate to change your mind that DPC docs are handling patient care under COVID-19 than anyone in U.S. primary care right now.
Telescopes in time, you won't, but okay.
Yeah, exactly. It is. I mean, everything that the healthcare system, that the traditional obsolete healthcare system, and it, for those listening in, it is anything built on the worn and rusted chassis that is fee for service, right? Any volume-based medicine, what the mainstream quote unquote medicine is trying to do and trying to pivot towards with value-based care and telehealth presence is what DPC docs have been doing since day one. I mean, that's what any DPC doc has been doing since the day they opened their practice. And oh, by the way, if you want to have good patient care via telehealth, turns out you need to have a decent relationship with your patient if they're going to listen to you. And it's pretty simple. It turns out that healthcare, and particularly primary care, is relational, and you can't build a relationship with someone if you're only seeing them for 15 minutes of full time, of which you are spending 9 minutes with your back to the patient typing on a computer, and the remaining 6 minutes just trying to process all the questions that you're like, I really hope they don't ask one more question. I hope they don't ask one more question because I'm out of time. And that doesn't build that isn't conducive to like having a genuine relationship.
It adds to their overhead. It adds to that feeling of helplessness, and it drives a lot to take it out on themselves in very bad ways. In some cases, as one of my guests, Dr. Pamela Weibel, who is the guardian angel of physicians, she deals with doctors, medical school students too, who are at the edge of their rope.
Yeah,
and she's been there.
And we use coded language, but when we say burnout and quote unquote systemic burnout and extreme burnout, like that is just a coded frame for this is a suicide risk, right? Like the suicide rate amongst American physicians is way high compared to the average norm. Like we're talking in the same range as combat veterans returning from like Iraq and Afghanistan. Like it is a major issue, and we hide that language, or we hide behind that language of burnout.
Don't you think it's important for people to understand that first of all, they should blame the system the doctor's in. Mm-hmm. It's the system that's abusing them, and that's something Shane Purcell wrapped my knuckles a little bit in a tweet when I use the term
very,
burnout.
very good at that.
Yeah, and rightly so. I really have learned more as time goes on about what that word means. People perceive it differently. But burnout doesn't mean there's a problem with the physician. It means there's a problem with the system that is literally abusing these docs.
And their goodwill and their humanitarian intent, right? Like it's the same framework that we have in America for public education and public educators, where it's like, we figure that if someone's moved to do good in society, then, well, they're going to do it no matter how poorly we treat them. So we might as well treat them as poorly as we can get away with. And that is as true of primary care physicians. Like,
I know. DPC Alliance helps. For people who don't know, DPC Alliance is a core group of people. Well, there's a group of people who've gotten together, DPC physicians, who help doctors make the transition from the old system, the obsolete system. And I keep repeating that because it is obsolete because of the personalization of medicine, amongst other things. You're helping these doctors go direct, meaning they transition to a membership type system.
Correct.
And I've read that COVID-19 is just being brutal to independent primary care physicians, not DPC. And they are essentially going out of business or getting there. Yeah. So let's just say for a moment, you've got a doctor that is in that old system.
So the fee-for-service, just hamster wheel.
Yes. And they're now looking at their practice, in another month or so, it could be all over. They're going to have to either do one of two things. Well, three things. Retire. Not many of them want to do that. They may, financially, they might be able to do it, but they're not living their purpose. And that can be even more harmful than staying in the system. Otherwise, they would have retired. The other option they have is being an employed physician for a health system. And then, of course, there's the preferred option, which is direct primary care. So tell me what's going on with our doctors calling you? Are they saying, point me in the right direction?
So we are seeing an uptick in interest in the direct primary care model. And a lot of it goes to, like you said, just the experience of independent primary care docs across the country in COVID. And these practices have been operating on razor thin margins. And many of them have stayed open, to your point, on principle for purpose, right? They are there embedded in their communities rather than being siloed to, the near site facility or working on effectively on campus to a hospital. So the employing system could get paid more. And they've really resisted integrating with the healthcare system or selling their practice. And now COVID just comes and train wrecks the entire business model for independent primary care in the fee-for-service model. So we are seeing an uptick in interest in direct primary care. And I think one of the things that we're seeing is a change in perception, right? So the Direct Primary Care Alliance and the various other entities and organizations that work to promote the direct primary care movement and membership-based medicine in general have a ton of work to do when it comes to educating the lay physician. Because most docs, like most human beings, and certainly most Americans, they prefer to keep their head down, do their work on a daily basis, and then just focus on their personal life. And they don't really pay attention to what's going on a national level when it comes to like interorganizational politics and the AAFP or the American College of Physicians. Like, who cares about that stuff? But those who do, they really care. And historically, there has been this mistaken perception that direct primary care is elitist and it is only serves the rich and the entitled in society, which is just way off mark. But it's hard to overcome this perception. And what we're seeing is a lot of practices go under. People are like, well, maybe I should cut these DPC docs a little bit of slack because they're still serving patients, they're still helping patients. And at the end of the day, if you're in fee-for-service and your practice closes, you may have thought that you were doing the best possible care possible, and maybe you were. I mean, maybe you were literally the best doctor in your entire community. But it doesn't matter how good of a doctor you are if your practice is closed. Like, you're not serving your patients anymore. By definition, you don't have a business, you don't have a practice, and those patients don't have a doctor anymore. And so there is a shifting perception in like how direct primary care can play to serve patient communities and meet the interest of patients of every type, right? We're talking every socioeconomic category, every racial category, any way you want to dice up the numbers, there are DPC docs serving patients.
Yeah. Yeah.
And as that perception changes, we will see this gradual inflow of firmly entrenched doctors saying, it wasn't that I was anti-DPC. It was literally just, I didn't think to look for something else, right? Like, but now my practice is closed. I kind of do need to look for something else. I've been forced into a situation to poke my head up out of the sand and say, what's going on? Like, what do I need to know?
Force majeure. Medicals. It's been a medical tsunami. So how does DPC Alliance, doctor calls you on the phone and says, okay, Joe, or whoever they reach out, how can the DPC Alliance help me? If you've got a couple of points that will make them think, this is a good idea.
Yeah. So there's a number of things that the DPC Alliance does. And the first and foremost is to put any DPC interested physician in contact with a mentor, in contact with someone who's been exactly where they are today, and help them understand what options are available, right? So you've had a number of direct primary care physicians on the podcast. Each one of their practices is different and has been perfectly built to meet the needs of their patients and themselves. And so no two DPC practices are exactly alike. That is the very definition of how we got into the situation we are with fee-for-service medicine, where everything got boiled down to trying to deliver uniform, practice assembly line type of care. Like, no DPC practice can be built just like, here, kit and caboodle, here you go. This is what you do. This is how you treat your patients. This is what they're not like. So they need to understand who to talk to and what the situation would be like for them if they are to move into direct primary care. Once they realize that it's for them, we can hook them up with tons of resources, both free educational resources around like, how do you build your DPC practice? What do you need to know? We can help them get discounts with major service vendors around just basic operational stuff. And so they can cut the cost of starting their business practice. And then once they are in DPC practices, and this is actually probably just as an important role within the DPC Alliance, we can help them be part of the community and the tribe of DPC docs, right? Like, there is no one, we are human beings. By our very physiology, we are social animals. And you need to be plugged into a community of peers and colleagues. And in any given town, there's probably not 15 DPC practices at this point in time. Right? So you're not going to have a social network entirely of local DPC docs. The DPC Alliance helps provide a framework for DPC docs to be part of the tribe and the community, and helps provide a framework for communicating and learning, cross-pollination and learning. Like, one of the things we do is hold, they started off as monthly. They're quickly accelerating to be more than monthly direct primary care ground rounds, right? So one DPC doc has an amazing clinical innovation and really just wants to share with the rest of the community. So we give them a platform. That type of cross-pollination that only happens within a tribe.
So one of the things I know you do is the DPC University, which you mentioned the education, and doctors will find a lot of resources available. I'd also like to point out that we're peers in this world of rearranging electrons in the form of podcasts and internet shows. And you have a show called carecast.icu.
Very, very nascent. The carecast is, we are still on getting episode 5 out, but it is a lifelong friend who is also a primary care transformation advocate, and myself, just trying to bring clarity to healthcare nomenclature. And at least that's my approach. Like, Lauren, my co-host, has a very different approach, but it's trying to make things understandable for anyone, quite frankly. Like, the healthcare policy is so full of jargon. Like, if I start talking about, MSSP ACOs and anything else, like, what does that even mean? Even doctors don't know what that means. Healthcare providers don't know it. Like, most policy people barely even know what it means. They just know it's a thing. And so trying to dispel some of the confusion by breaking down, like you do, quite frankly, what care really means, and helping bring tangible understanding of, like, well, an MSSP ACO is a Medicare shared savings program, accountable care organization. And even that is undecipherable. So let's go through that terminology and say, what is an accountable care organization? And do they work? Do they not work? That kind of thing.
You guys are going to have you're going to have plenty of material coming up. I just read I read one of the party platforms that was released this week, and I jumped to the healthcare section and I looked through it. Same old thing.
Yeah.
It's all about coverage. There's very little in there.
That is one of the shocking truisms in healthcare and healthcare transformation. All the political fights that we have for healthcare transformation in the US, they're not about healthcare. They're about healthcare insurance, right? So, like, the Affordable Care Act, those words are about how do you make care affordable? And the answer to that is, well, we get more insurance. And all the counter responses are, well, how do you manage who pays for the insurance, rather than how do we actually change the healthcare that Americans receive?
Yeah.
And
starting with primary care.
Yeah, necessarily starting with primary care. In the most absolute sense, I've never encountered a functional vision of a healthcare system that doesn't build itself upon high functioning primary care. Like, I've desperately tried to understand a quote unquote a competing vision for care delivery that wouldn't be integrated upon a chassis of primary care, and it just isn't there. Like, you can't have functional, high quality healthcare that is entirely based in high cost inpatient institutions, or you can't replace a primary care physician with an algorithm and just only focus on specialists. Like, that's just if anything, the past 20-30 years have been a trial to that end, and it's not like we've had good results from that trial. Like, the over specialization of healthcare has been nothing but negative.
Yeah.
Unless you're like a billionaire who can literally afford to fly from one specialist to the next, because you employ 10 people who hook up every single potential thing that you need, and you can identify every specialist that will service your specific needs. But unfortunately, we're not all that billionaire, and there's not enough of those type of physicians who can provide that level of care. Like, it just doesn't work for a nation. The true beauties of the direct primary care model. And back in 2011, this is one of the things I realized really quickly that is unbelievably powerful, right? So I don't know if you've had the pleasure of talking with Dr. Samir Kamar, right? So he back in the day had a company called MedLion, which was kind of focusing on employer-based direct primary care. Now he's in in remote diagnostic technologies with MedWand.
Mm-hmm.
But he was telling me his experience coming out of a very high cost, high impact direct primary care framework, and he had moved out of this himself. But like, his patients were the type of people where if they got sick, rather than coming to see him, they would book a private plane for him to fly to wherever they were, and he would fly to where they were, take care of them, and be flown home. So you can have that framework side by side with a second year resident. I wish I could find him now, who gave me a business plan about what he was going to do as soon as he graduated, as soon as he finished his residency, which was start a direct primary care practice serving indigent and undocumented workers around poultry farms in Colorado. And other than the whole being flown back and forth bit, like, the same business model, just entirely different applications of it, right? And it worked for both of those communities. The same framework and the same principles and the same human level care can be scaled from $15 a month to, I don't even want to know how much, like your friend that works at Presidential Med, I think, gets paid. Like, I literally don't want to know. And everything in between, right? But any physician can build a business and a practice that suits the needs of their patient community that they serve.
Yeah.
With applying the same business principles.
The funny thing is, DPC has an advantage. You mentioned a community there of undocumented people. And undocumented can mean a lot of different things. It can mean people who arrived and living in Panama. I see them all the time coming through, because they come right through here.
Mm-hmm.
And on their way up north. And it's important to understand that not everyone is a, quote, illegal alien. There are people who are undocumented temporarily because the papers haven't come through. So there's a lot of different situations.
Yeah, absolutely.
So one of the things that I picked up on is that direct primary care, if we had direct primary care as the standard of care, those people would not fear going to the doctor, which they do now.
Absolutely.
They don't want to pop up on the radar screen.
Yeah. And even if they are, and so when I lived in Kansas City, I lived in a neighborhood called the West Side, which is now for those familiar with Kansas City, this is true of just about every market. It was a historically low income minority community on a very pretty hill. And at the time, my wife and I were living in a 2-bedroom house where the rent was $500. And we were the only people of Mexican descent in the whole community. And everyone else, like the neighbor to our left was born in the house that we were living in. The neighbor on our right was born in that house. Like, these are people whose families had been on that hill for 4 generations. And they still didn't trust systems, right? They still, they weren't afraid of being deported, but there's a number of break-ins, and I would get calls at work from my neighbors being like, "Hey, Joe, you have to call the cops." I'm like, why are you calling me? Why do I need to call the cops? Well, they don't treat us well, and they'll tell by your voice that they should listen, which is like, these are the people who don't want to at all to be involved with any formal institutions in society. And that includes doctors. And believe me, both of my neighbors, elderly, both past 60, really needed a doctor who could sit them down and help them. But they didn't. They wouldn't talk to them.
It's not just here either. It happens in Canada.
Yeah. I mean, it probably happens everywhere, right? Quite frankly.
Well, we have this issue. I can tell you that when well, I won't go in too much, but when the train stopped for a few months going north, it literally the train, the line of people started backing up because Guatemala closed their border. Mm-hmm. And then it just, the ripple effect wound up in Panama. And all of a sudden you've got 3,000 people on the western edge of Panama who are sitting in camps. And the Panamanians were starting to complain, excuse me, why are we helping treat all them when we're not getting the care that, It's amazing what happens when stuff hits the fan. And that's certainly what COVID-19 has done.
That is absolutely true.
Telemedicine is now at the forefront. And I think CMS is saying that they're not going to go back to the old way of doing things with that. People are kind of enjoying getting a hold of their doctors. At least that's what I read.
So CMS has made that declaration, and genuinely speaking, like, I suspect that we can hold them to that. But I don't know if change is here to stay. Like, and I'm afraid that I am pessimistic. Right? I've been working in healthcare transformation for over a decade. And
where do you live, Joe?
So yeah,
DC.
DC. Though, I mean, much of my life and my work has been not in DC around healthcare, but we are a very change resistant institution and industry, and we are very, we are still set in kind of a professional guild mindset, both on the provider side with physicians and everyone else, but also on the payer side. And so when payers say, "Oh yeah, we're absolutely we're gonna pay for advanced quality and telehealth and parity with in-person visits," I'm like, you say that now because everyone's freaking around COVID, but I don't know if that will stay true down the way. Like, we don't. And again, maybe I'm just overly pessimistic, but like, I hope that the changes that we've seen and that we've gained for the vast majority of patients stay open. I hope that telehealth stays effective and paid at parity. I don't know if it will.
I've so enjoyed meeting people in the community, and I love their attitude. I love the entrepreneurship, because I'm a serial entrepreneur, and they've been so forthcoming and so joyful about what they do. I mean, it's not that complex. Anyone can figure this out. People who love what they do, they're a good interview, right?
Yeah, I mean, that's actually one of the things I can share is you're right. I mean, like, it's a business model that basically says, hey, get paid for what you provide up front and build relationships. That is a very simple framework for any mercantile relationship. And one of the real powers of direct primary care is, and I say this right at the tail end of the interview, of course, was the fact that it is so simple and so common sense that we didn't need anyone to tell us. Like, in my seat at the AFP, I didn't need to go to doctors and say, hey, you should be doing this. It was a matter of convergent evolution, right? So we had doctors all across the country in the span of within 5-10 years coming to the same conclusion, basically being like, my current system of fee-for-service medicine doesn't work. Just doesn't work. So what can work? Well, I want to be paid on like a per member per month framework. What does that look like? Well, I could take care of 400, 600, 800 patients. And if I don't want to see 30 patients a day, let's do the math. And how many, 12 patients, 6 patient visits a day. Well, maybe I should charge X dollars. And you literally saw people on both coasts coming to the same conclusions, really in the same time period, because it is, like you said, it's simple. And that's one of the beauties of the model.
Yeah.
No one needs, we don't need CMS. We don't need even state governments saying, hey, doctors, let me tell you about this funny thing called membership-based medicine, and this is how you do it. Like, they can figure it out for themselves, and they did figure it out for themselves. And there are leaders in this movement, and we, all credit to, the doctors Garrison Bliss and Eric Bliss out of Seattle, Dr. Brian Forrest out of North Carolina, Dr. Josh Umber out of Kansas, and this whole cadre, Sam Kamar, Dr. Kamar out of Las Vegas, this whole cadre of early pioneers that really came to the same conclusion. And they'll all say, I invented this. And they're all telling you the truth. They did. And they all built the same business model because it is a functional, simple business model. So it is, simplicity is powerful.
There's majesty in simplicity, as my dad would say. Yeah. Joe Grundy, I've enjoyed this conversation. Thanks so much.
Hunter, it has been awesome chatting with you. And thank you for all the work that you're doing, trying to help people understand what high impact primary care actually is. We all owe you a debt of gratitude for that.
No, it's been my pleasure, really. So this is Hunter Schultz for Winning Healthcare Food Fights Without the Mess. Stay healthy, wash your hands a lot, and there you are.
you.